Good morning. I'm John Bitson, the Menard Family Director of the Sheila and Robert Challey Institute for Global Innovation and Growth. Welcome to the Human Progress and Flourishing Workshop. In this workshop, we bring in thought leaders from across the country to engage in a discussion with the NDSU community about insights from their research and other experiences. And I'm super excited that today we're joined by Dr. Alicia Plemmons from West Virginia University, somebody who is a bundle of energy. So again, right now I'm trying to bring my energy level up, but her energy level is going to be ceiling high. So again, I'm not trying to put pressure on you, but she does have a lot of energy. So I'm excited that she's here, and she has a super exciting topic. She's talking about medical licensure and healthcare policy solutions. And I think that a lot of people are not necessarily familiar with occupational licensing and scope of practice laws. And I think you'll learn a lot today, and I've learned a lot just visiting with, I knew some about this, but just visiting in the last few minutes, I've learned a ton from Alicia in the last day as well. So I'm really excited about it. And so Dr. Alicia Plemmons is an assistant professor in the Department of General Business. She's a research fellow and coordinator of the scope of practice research in the NE Center for the Study of Occupational Regulation, and a resident scholar of data-driven West Virginia. She additionally is a program coordinator for both the Masters of Business Administration and the online Master of Business Administration programs. Her research uses applied spatial and econometric methods to determine how policy changes affect labor markets by studying how to create environments that facilitate healthy economic growth and business development through research into the determinants of entry, operation, and exit decisions of firms, laborers, and consumers. Her research has been published in numerous academic journals, such as the British Journal of Industrial Relations, Health Economics, and Annals of Regional Science. Her work on medical licensure and certificate of need laws has been featured in several news outlets. She has regularly been asked to provide professional testimony on occupational licensing for both state and federal legislatures. And Alicia is a great example of somebody who does great research, and it has a really big impact on society. I'm super impressed and super excited. So you're going to have your own opportunity to ask questions of Alicia when she's done, about 10 minutes or so. And so please get your questions ready and be able to ask her questions. Without any further delay, let's welcome Dr. Alicia Plemmons.
I'm already dropping things, but that's all right. Good morning, everyone. How are you doing? Good, good. Oh, that's actually a lot of energy for 10 a.m. on a Friday. I'm very impressed that you're here. My students would not be waking up by now. But it is so great to talk with you all today, especially on a topic that I really care about, which is thinking about medical licensing. I myself am from a small town that didn't always have access to healthcare providers, especially when I was younger. We have more access now, but it took a while. And that really frustrated me and got me into the idea of what are the barriers that are there that are keeping providers who want to provide medicine and medical resources to communities that need it. And is there ways that we could approach those barriers and figure out what can we do better? And that's a lot of where I came to, especially when it came to licensure. So a lot of people may not understand licensure. So today what we're going to do is we're first going to talk about what is medical licensure, so that I'm not just spouting out a whole bunch of words that you may not know. After that, we're going to talk a little bit about the big questions, go over some studies, and then I'm going to talk about what's happening in North Dakota specifically, because I think it's really important to stay engaged with what's happening in your own backyard. Okay? So what is occupational licensing? Back in the 1940s, about 5% of people needed a license to do their job. These are the big ones that you normally think about, like, a lawyer has to pass the bar exam. A physician, they have to go to medical school and get a medical degree and get a medical license. An accountant. But today, this has really grown, especially through the progressive era. We've had a lot of creep into which jobs require occupational licensing. Today, it's about 22% of jobs in the US require government permission to do your job. So that's everything from your construction workers to your teachers to just about anything else you can think of. And that can sometimes be a huge barrier because each of these occupational licenses actually require a lot of things that come along with them. That means that to get that license, you need to complete certain amounts of education and experience requirements. You may have had to do apprenticeships. You may have had to do internships. You typically have to pay fees. And for someone who's trying to start a job, having the amount of money to pay fees that might be hundreds or thousands of dollars is very expensive and burdensome, right? There's also tests of good moral character. A lot of the time people may be denied licenses for something that they did decades ago. For example, we've had a few physicians that were unable to get their medical license even after going through all the training, all the classes and everything else because they happened to have had a fake ID when they were 18, which is completely unrelated to solving medicine problems in your 30s. So these are things that we sort of wanted to think about sort of these requirements and how they affect different professions and how people are able to enter certain professions. Now, within healthcare itself, we go a little bit further. So in many professions, things differ by state. For example, I spent a few years in Illinois. They're the only place who has a license for milk samplers. Louisiana is the only place that has a license for florists. The rules to be a police officer or a cosmetologist are drastically different depending on what state that you're in. It might be 100 hours of education, it might be 2,000 hours of education. And that can change a lot depending on where you are. Healthcare is a little different. Healthcare is more, I wouldn't necessarily say standardized, but more universally licensed. Every single state has a license for physicians. Every single state has a license for nurses. Every single state has a license for your dentist. But what they can do with that license and the requirements for that license, that can be different. So a lot of what my research is looking at how these places are different and how it may be affecting cost, access, and quality of care. So what you're going to hear me talk a lot about today is scope of practice. It means for any non-physician what they can actually do with their license. While a nurse practitioner may have the exact same training no matter what school they go to, they may not be able to prescribe medicine in Georgia, or they may not be able to diagnose patients or refer patients to specialists in Alabama. Or in places like North Dakota, which was one of the first to change their laws on nurse practitioners, they can do almost everything related to primary care and are recognized primary care providers. So this scope of practice and what someone can actually do with their license once they have it, and especially in healthcare, is really, really important to understanding not only what people can do with healthcare, but the access to healthcare in rural communities. If physicians are the only ones who can see you, it's very difficult to get physicians to go to a place that may have 250, 260 people. It's a lot easier, though, to be able to get a nurse practitioner to go there to at least provide primary care and be able to refer individuals who need more help to specialists over the next town or the next city or somewhere else. So how can we create these sorts of solutions by addressing these scope of practice issues that come in related to healthcare? So this is one thing that I know really surprises students. So it's kind of where I want to start with, and it's how are these scopes of practice determined? A lot of people are really surprised to know it's not necessarily the association that you're with. The American Medical Association and the American Nursing Association, the American Association of Nurse Practitioners, all these other groups, they don't actually set what you can do within each state. Most rules related to licensing for medical is actually done through the state legislature. So that means if you want nurse practitioners to be able to prescribe medicine, or you want pharmacists to be able to give more people inhalers for asthma attacks, or anything related to that, it's typically people on the Health and Human Services Committee or the Department of Labor or anything else that might be within the state legislature. Okay, following me so far? So while some of these things might have recommendations from different healthcare professionals, a lot of it's based in did the House and Senate or joint committee within that state say that this is something that they can do? Did it get through committee? Was it voted for in the full assembly? And what did the licensing boards say? Licensing boards aren't only made up of healthcare practitioners. Sometimes they're made up of people currently working within that field, which I know you're going to be very surprised by this. Not really. People currently working in the field don't always want more competition, so they aren't always wanting more providers to be in an area. They also might have representation from the community, from legislators, from healthcare insurance companies, and a bunch of other things. Okay? So this scope of practice can be widely different depending on what sort of profession that we're thinking about. It can be everything from can your dental hygienist clean your teeth to can your nurse practitioner help you get past surgery and really help you work through that healing process, right? Okay, so this scope of practice I think is extremely interesting because we're facing a healthcare shortage, right? There's not enough physicians. Even before the COVID-19 pandemic, we were really expecting there to be about a shortage of 14,000 primary care physicians and about 6,000 psychiatrists. These numbers have massively grown. Now, if we're thinking about not only primary care, but all specialized care for different types of physicians, by the time 2035 comes around, we're expecting that shortage to be close to 135,000. That is a lot of missing physicians from the system. So what are we going to do for a lot of these communities that may not have access to these physicians? Because if you have fewer ones, where do they locate? They locate in major metropolitan areas. They go to states where there may be a few million people that they can service and be able to charge services to. They're not necessarily going to communities that may be the most in need of these services. So that's something that we need to think about, is what's happening. So one policy that my center in particular works on is scope of practice. So you'll hear me refer to the NE Center a few times. We're a center in West Virginia, which has a similar sort of rural-based population. And what we do is we work with all 50 states related to these different sorts of laws. So we don't advocate for any particular policy, but we do educate legislators. So for example, if something comes by saying, hey, we're debating on giving nurse practitioners the right to prescribe antibiotics in this state. A lot of what we do is we come in and we do research and we say, okay, this is how many lives might be saved. This is how many people might be affected by this policy. This is what's going to happen to sort of the cost of services, to be able to help them understand what might happen within their community. Okay? And it's actually a lot of fun. It's pretty neat. That means for the legislative session, we're going all over the place. Now, the legislative session in North Dakota is every 2 years, correct? On odd number years. So everything that I'm talking about now are bills that might be being considered, they might be being written up, but they're not going to be introduced until next year. So it's kind of nice to know what might be coming on the horizon, especially in North Dakota, which was one of the first ones to change scope of practice laws to begin with. All right, so everything I want to talk about is really based on this fundamental idea of healthcare. And it's how do policies affect sort of this iron triangle of healthcare? We have three things we're always trying to balance. It's quality, access, and cost. And the problem is they don't always work together. If I'm wanting to increase access, that might drive up cost, or it might affect the quality of services. If I really want to increase the quality of services, that's going to make costs more expensive. And it might make things less accessible. There's lots of different ways that these all interact together that make it very, very difficult to figure out what can we do for healthcare itself, because we have three different competing things to think about. One of the reasons why we really focus on scope of practice is because it's one of the few policies we see that have really interesting interactions with all three. I'm going to go through a lot of the really interesting studies, especially studies that have been done in North Dakota, but a lot of what we found in general with scope of practice, in about 96% of the literature, is that typically cost will go down when we expand scope of practice, because it means that there's more providers who can provide this service. If your dental hygienist can clean your teeth, your dental bills go down. That has not happened in North Dakota yet. If your nurse practitioner can also give you primary care services, they bill at 85% of the rate of a physician, especially for Medicare beneficiaries, which means that the costs are a little bit cheaper for those services. We also know that access goes up because now we have more providers who are able to give you those essential services. So then the question that we are most concerned about is what happens to quality. Because it doesn't matter if you raise access and make everything super cheap if everybody's not getting the quality services that they deserve or need, right? So we are very interested in what happens to this quality metrics. Is it still safe for patients? The original licenses that came in, especially in the very beginning of the United States in 1780 or so, we had the original licenses for the three main healthcare groups at the time: apothecaries, physicians, and surgeons. When we're thinking about this, those original licenses were to be able to describe to someone that someone had a background in medicine, that they had study, because you didn't have an Angie's List back then. You didn't have your Google star reviews. You needed something to be able to signify safety and quality of a provider. Now the world's changed a lot. We have more information. We can look up at any time if a doctor went to certain types of medical schools. We can look at what other patients have thought about them. We can look at where they're covered for insurance. So as information has grown, licensing's also grown. We have to think about, is this still for the purpose of safety and information? Is it affecting quality? And it turns out most of the time it doesn't, but we'll talk about the little differences depending on which group we're talking about. So let me give you an example of this. And this is actually a study that I'm very proud of because it's affected legislation very actively. And that's thinking about psychology scope of practice. So if you ever have a crisis, right, a mental or behavioral crisis, which I definitely did when I was in school. So if any of y'all do, I'm feeling you right now. But sometimes it's very difficult to get medicine and treatment for that crisis, right? The normal way that it goes in most states is that you identify that you need help. You go see a psychologist, and getting matched with a psychologist and getting an appointment with a psychologist and getting initial diagnosis, that can take about 6 to 8 weeks, okay? Then after that, in most states, psychologists have no rights to go ahead and start medication for you. So to be able to start any medication that you might need for a chemical imbalance or whatever else is going on, you have to be referred to a psychiatrist. Well, there's far fewer psychiatrists than there are psychologists. There's about a fifth of the amount of psychiatrists, which means you're waiting another 6 to 8 weeks to be able to get an appointment with that person, to be able to see them, to be able to get recommended for medicine, to be able to get medicine filled, which can take 0 to 6 weeks to be able to get that medicine filled because it might take time to be able to get testing back. So that means for some people in crisis, it might take 2 or 3 months for them to start receiving care that they identified that they needed at the beginning. One policy that ended up going through, and it started in New Mexico, then eventually went to Louisiana, Illinois, Iowa, Idaho, and most recently Colorado, and soon Utah, because we just worked with the Department of Commerce in Utah to figure out what would be happening to suicide rates within their own states. We found that when you instead limit this amount of time, you let the psychologist start the medicine, right? They say, wow, you are going through crisis. We're going to start you on medicine right now, and then you're going to go see your psychiatrist. Getting people the medicine that they might need 6 to 8 weeks sooner had a lot of impact. Not only was it helping decrease suicide rates in these states substantially, but it was also helping people get care that they needed faster, because a lot of people who are in crisis, when they start to get care, may not follow through 3 months of appointments. They're kind of needing care then. So this was a really interesting type of study that we looked at for the scope of practice for psychologists themselves. Did they have the right to be able to start medications? And this is something really interesting, especially when we're talking about places that may not have the same access. Many of the counties within North Dakota, I think it's 40 counties, but we're going to be looking at it at a later slide, don't have enough mental health care providers to be able to service the mental health care needs of that county. And that's a lot. That's a lot of counties who need more help here. So if we can start to think about how can we make this transition faster, then that's a lot of the ways of being able to think about how can we help these community members in a way that matches the services that they have available to them. If there's 4 psychologists within a county and no psychiatrists, which have actually happened in a couple counties here, what do we do to be able to get these patients help when they need help? Right? And that's why I think scope of practice is such a fascinating thing to research, because we're not only talking about how can you make someone's life better with a cold, or how can you make someone's life better with, I don't know, a lice breakout in an elementary school. We're talking about things that can affect long-term health outcomes. We're talking about things that can affect people's mental well-being. We're talking about things that can affect, for example, a lot of scope of practice relates to the rights to be able to give inhalers and insulin. We're talking about the ability to manage things such as diabetes and asthma, and where can we be able to get medicine to people who might need medicine. And a lot of it's just realizing there's not providers everywhere. So if there's not providers everywhere, what can we do to adjust this? Because human flourishing requires being able to be healthy to go through and flourish, right? So one of the things that we saw in this study in particular was that there was a reduction in suicide, more mental health providers, and there was no negative effects on quality and safety. It turns out people were just getting as good of medical care. They were just getting medical care way faster. And that's neat. That's neat. That's actually why I love studying scope of practice so much, is because it's one of the few things that we found where there's actually real world policy implications. So within my center, we work with lots of different states when these policies go up. For most economists, and I'm very sad picking on the economist here, most of the time you sit in a gray office coding up different equations that you never really see any impact into your world. A lot of what we got working from these sorts of things was being able to make real life impact of saving lives or providing services to people who really needed services. For example, there's labor and delivery services in Alabama and different parts of West Virginia that weren't there years ago because we looked at some of these laws, realized they were affecting where midwives could go. Especially in counties where there were no labor and delivery services in a hospital, you might need midwives in those areas. So readjusting those laws made it so that there were finally services for the first time ever. So that's kind of neat, but it's really weird to know that these are affecting everybody in your life. Because it's not just psychologists. It turns out that scope of practice affects a wide variety of things. It's everything from your dental hygienist to your audiologist to your nurse practitioners to your orthodontist, all the way to, if you're like me and like your pet more than you like people, your vet. You got to care about the vet. That normally gets a laugh. Thank you for whoever snickered over there. I very much appreciate it. Because it turns out, who has the right to, if your pet's in crisis, if they're going to the emergency room right now, the number of providers within that office that can actually give an x-ray or start fluids for your pet to make sure that your pet can live is very different by state. In some states, it's only the veterinary, and in other states, you can't have veterinary technicians who are able to start some of the medications until the vet can get into the room. And that can sometimes be a difference in between healthcare or no healthcare. Isn't that kind of cool? Isn't that also kind of frustrating to realize, wow, there are a bunch of people in Congress who are determining if people who all have the same amount of training can give me a service or not? So that's why we found this very, very interesting to think about, because this affects almost everything when it comes to medicine. All right. So I'm going to go through a couple very distinct groups and talk a little bit about what the research has found for them so that you understand what's happening in different spheres. So the first set of groups that I want to talk about is nurse practitioners and physician assistants. Last time you went to the doctor's office, and I am going to ask for a show of hands because we have participation here. Last time you went to the doctor's office, are you really sure that your doctor or the person that you saw had an MD or a DO or an NP or a PA or anything else? Like, who's very confident about what credentials they had? Half? Okay. And then let's think. How many of you have realized, oh, I really don't feel good today. I would like to see someone very quickly. And you thought about maybe going to a CVS or a Walgreens or something like that to be able to go quickly see a provider at a minute clinic for something right then. Some? Okay, all right. Typically that gets more, but then I forget that students actually have insurance. So two different types of groups who might be providing primary care are also nurse practitioners and physician assistants. These are people who also have PhDs. They've spent lots of time in clinical hours. The difference between them and physicians is that they didn't go through a residency program. A lot of the reason why some people might become nurse practitioners is because there's a limit on the number of residencies available in the United States that's set by the federal government, because they only reimburse so many residencies across the US each year. If you have a ton of people going to medical school and not all of them can get residencies, then you might have some of them who decide to instead become a nurse practitioner and go do clinical hours and get their PhD in providing medicine through that sort of way and that sort of care and have years of experience through that means. So a lot of these are the same healthcare providers who have a lot of the same background and experience with patients, but what they can do is a little different. So physicians have their medical license. Nurse practitioners and physician assistants also have a medical license in their own respective fields, but what they can do if it's a little different. Now, physicians like money. Everybody likes money. Let's be real. If you say you don't, you're wrong. Everybody likes money. Physicians often will specialize in things that are very specific. Has anybody seen Grey's Anatomy? Memes from Grey's Anatomy? All right, wonderful. All right, so what you've seen there in Grey's Anatomy or many of these other medical shows is that people go in and they're wondering what specialty they want to go into. Do they want to go into surgery? Do they want to go into cardiology? Are they really interested in neurology? A lot of the time, most physicians in the US, about 9 out of every 10, will end up going into some sort of specialty, while the remaining 1/10 will stay in family care or primary care. That's very few providers who are staying within something to be able to provide sort of the daily needs, the antibiotic needs, the checking out and like doing your physical needs, because it just reimburses less. On the other hand, nurse practitioners, 86% of them will end up going into family medicine. They're the ones who are willing to go to that minute clinic and provide services in a place that may not have a hospital available, so that like if you have a cough, you can get it checked out. So you know if you need to go to a hospital. They're the ones that you might have within sort of your family practice, providing healthcare. Now, what they can do in different states is very, very different. We call this either full scope of practice, reduced scope of practice, or restricted scope of practice. And those are the 3 different types of rules we have in each state. Within North Dakota, you have full scope of practice. You were actually one of the first states to change, and this was in 2011, because there were a lot of counties that did not have primary healthcare physicians available. So they said, okay, we can't get physicians to go to a lot of counties. We need to go from no healthcare to some healthcare, right? Any healthcare benefits better. Let's think about what we can do. And what a lot of your legislators did at that point was saying, okay, let's give the right to nurse practitioners to be able to go work on their own. They don't have to have a physician within the same building. They can maybe call a physician to talk to if something's going wrong. They can call a physician to be able to bounce ideas off of them to figure out what's going on with you. But to be able to get people there, to provide this primary care, to start this initial care in many different communities, we're just going to let nurse practitioners do what they need to do. They can now provide antibiotics. They can now go provide primary care services. And this is one of the first states that allowed that to happen. This was actually one of the first states that saw, for the first time ever, really good impacts happening in the most rural of communities under 20 or 50,000 individuals. Because now you had a lot more providers available for things that people may need. Similar with physician assistants. While they may have full scope of practice, which is in very, very few states, nurse practitioners are the ones that have a lot more expansion. There are many that also have reduced or restricted. Reduced or restricted just means that you have to work in collaboration with a physician or supervision of a physician. Maybe you have to have a physician in the same room. And it's also restrictions on one or more different services that you can provide. So it's a restriction on providing medicine or diagnosing patients or providing x-rays or being able to refer patients to other specialized clinics. So this difference is actually really big, because you're talking about moving from a very select few physicians who might be providing family care or primary care or those everyday needs that you might have, to moving to not only those physicians, but also having 86% of the nurse practitioners within your state also being willing to provide this primary care to individuals. So you're probably asking me, what does the research find? And if you're not asking me that, that's okay. I'm going to tell you anyways. A lot of what the research finds is that costs go down, right? Let's think about the triangle I was talking about with cost, access, and quality. Cost goes down. Nurse practitioners bill at 85% the rate of a physician, and that is a federal law related to Medicare beneficiaries, which is why most insurance companies reimburse at that exact same rate. Access goes up. You now have far more providers in an area, and many areas that had no providers now have some providers. Great improvement, very wonderful. And then quality. So it turns out we have about 300 different studies that have been done on the quality of nurse practitioners once they're given full scope of practice. And most of those studies were actually done in part in North Dakota, which is really cool, and using a lot of North Dakota data. It turned out quality overall just wasn't really affected at all. Almost every study has found that quality stays about the same. There's not a lot more. Nurse practitioners actually prescribe less opioids than physicians do. A lot of people were worried when you let nurse practitioners prescribe medication, is the opioid epidemic going to get worse? Turns out they were very nervous about losing their license. They didn't really prescribe opioids at all, so that fear went out the window. The only difference in quality that we found that was significant was that they do tend to order more tests. So they will ask for an extra test to confirm that you have a diagnosis before fully diagnosing you with something and starting a treatment plan. So quality remains about the same. That is one of the few things when we look at that triangle of healthcare that we're actually making improvements in all three categories of keeping quality the same, but giving people more providers. And that's really neat. So physician assistants, or sometimes you might hear them called physician associates, because that's one of the rebrandings that they're trying to do right now, are very similar. They have worked with physicians for a long time. They also have a PhD. They've also done clinical hours. But what they can do is very determined by states. Within some states, it might be that they work together with a physician, and a physician says, you know what, I've been supervising you for 3 years. I trust you to go into those rooms and figure out what's wrong with the patient so that I can spend time actually developing the treatment plans. They work together. They figure out their ways that they provide services. But to be able to do that at all, you need to be able to have physician assistants there to work with those physicians. Okay? All right, optometrists. This is a really interesting one. I'm seeing not as many blind people in here as what I would have expected. I am blind. It's not fun. So within most states, ophthalmologists are the ones who will give you the really intensive need things, right? So this made sense back in the 1970s when laser eye surgery in the 1970s was very sketchy, and I would not have recommended it, right? Like that was at the very early times of this was invasive. It was time consuming. It had a high failure rate. The people who were working on it were people who had gone through extensive training. Over time, since the 1970s, one of the things that we've seen sort of change is the role of technology. Technology got way better. To treat glaucoma in the mid-1970s, when the rules for optometrists, which are the ones that when you go to get glasses, you're meeting with an optometrist who looks at your eyes and everything else. The roles of technology have changed so much that now some states said, okay, well, glaucoma is no longer a giant invasive thing where they're cutting open your eye. Now it's eye drops. We're going to let the optometrist that you see for your glasses also be able to give you eye drops for glaucoma. We're going to let the optometrist that you see for your glasses also be able to do laser eye surgery, because at this point it is completely done by computers. You are sitting there while someone is watching to make sure that nothing goes wrong. As the roles of technology has changed, the roles of optometrists have changed, but not every state has changed with it. I think North Dakota, if I'm not mistaken, is one of the few who have not actually moved into allowing optometrists to do more things, which means to be able to get something such as glaucoma medication or anything like this, you're going to have to go to an ophthalmologist. That's a whole other meeting. That's 6 to 8 weeks delaying in care, and that's way more expensive. So that's something that we need to think about, because how many of y'all are from small towns? Okay, same. My town did not have an ophthalmologist. We had one eye med that charged you way too much because it was the only place to get glasses in town, right? But it would have been really nice if I was able to get some of the assistance I needed for my eyes within my own town, instead of having to go there, pay a ton of money, then get referred to someone at a big city an hour and a half away that was very difficult to get an appointment with, go there, then get my eyes to see. What we're trying to talk about here is being able to limit that process and make it more accessible and affordable for people. Other things are psychologists, like what I was talking about earlier. Psychologist prescriptive authority is a type of scope of practice allowing medicine to be able to get to individuals earlier. Suicide rates go down, and we actually get more psychologists. And the same amount of psychiatrists. It's not a substitute, it's actually a complement. It really helps psychiatrists in these states if psychologists are able to start addressing the problems of those patients, and then they're able to see all these patients that have already started treatment. Pharmacist is another one. So this is the really big thing that I'm working on right now, and it's the one that I'm the most excited about. So there's a lot of really interesting stuff that's happened in Idaho and now Montana, and that's probably going to be going to a lot of other states coming up. And I would bet money that North Dakota will be presenting this in the next legislative session. Idaho, back in 2019 and into the pandemic, they were the first ones to say, you know what, we need help. We have a lot of people with diabetes. We have a lot of people living with asthma, and we have very, very few endocrinologists and allergists and people that you would typically see for these things. I think within the state of Idaho, there was only 56 or so endocrinologists for thousands and thousands of people living with diabetes. So diabetes and asthma are both something that you live with basically your entire life. It does not go away. There are many people who have been on the same medication for a really long amount of time. So what Idaho said is, okay, you know what? These are things that if you don't get treatment, they get worse. These are things that people are going to the emergency room for, and we don't have a lot of beds in our emergency rooms. We can't have 4 of those beds taken up by asthma attacks. We can't do that. So what are we going to do? You know what? We're going to start reimagining the role of the pharmacist. These people who know medication better than anybody, and they have been sitting there working with this patient for the last 10 years on managing what they're going through. We're going to allow the pharmacist to have some roles of prescriptive authority themselves, that they can say, hey, you have the flu, here are some meds. You have lice, here are some meds. But also, you have diabetes. I have been treating you for diabetes for 10 years, and you ran out of your insulin, and the next meeting with the endocrinologist 3 hours away is 2 weeks from now. If someone living with diabetes goes without insulin for 2 weeks, that is a very high rate of ways that they may end up in the emergency room, or things may end up getting worse that can be significantly detrimental to their lives. Same with asthma. If it took you an additional 2 weeks to get an inhaler, especially for maybe your children who are still learning how to manage their asthma or things like that, that delay in care can cause lots of trips to the emergency room. It can cause families to go into medical debt that can ruin the rest of their lives, right? It can cause medical bankruptcy. So Idaho reimagined this and said, we're going to allow pharmacists to be able to give these things. You know what? If that kid runs out of an inhaler and you can't get to a doctor, go to your pharmacist, ask for an inhaler. They'll give you an inhaler, and then we'll deal with everything at the doctor's later. What do you think happened? Okay, well, I'm gonna tell you anyways. Good, yeah? Went up? Care got better. It turned out all of a sudden, once we allowed these pharmacists to do that, there was a lot more inhalers going to people who needed inhalers, and a lot less people going to the emergency room because they were having asthma attacks. That is so cool, because it's one of those things that, like, this is a very simple policy to change. It costs nothing to the state. but it's saving people hundreds of thousands of dollars and saving lives, right? So since then, Montana has now also adopted this policy. They adopted it in the last cycle. And it's one of the few scope of practice policies we've seen that have now become extremely popular to consider. A lot of states are thinking about putting this up in the next year because they realize that this is a low cost, easy solution to be able to get critical care to people by reanalyzing the scope of practice of pharmacists. So scope of practice is not only who you're going to go see for when you have a cold, but it's also what resources do you have available to you, because that's not actually determined by the skill set of the provider. Your pharmacist knows your medication. And if you have an insulin prescription, they have been working with you for a long time. They know your insulin prescription and they know the insulin prescription of hundreds of other people. They're very well informed, but giving them the right to, if you ran out of insulin, to hand you more insulin until you can get to a doctor, that's very different. So that's one that I think will probably go up in North Dakota in the upcoming legislative session, is reimagining this. Because while Idaho had 56 endocrinologists to be able to work with diabetes, and they had about 40 or 50 or so allergists to be able to work with asthma, they had 1,900 pharmacists. Every single community, whether it was 200 people, 2,000 people, or 20,000 people, had a pharmacist available to them. So it drastically changed rural healthcare in these areas. So let's talk about North Dakota specifically, and this is going to be where you might get mad about a few things. North Dakota has, 53 counties? Out of those 53 counties, 46, at least in part, are considered primary care shortage areas. They do not have enough primary care providers. Now, this definition only includes physicians in it. It doesn't include the expansion of nurse practitioners. If so, you actually have fewer counties. But that's still a lot of places. 40 of these 46 counties, the entire county doesn't have enough physicians, not just parts of it. That's a lot of places that don't have enough physicians available to them. Other things that we need to think about is dental care. It turns out dental care in rural areas might be very hard to obtain. Actually, 20 of the counties within North Dakota have dental care shortage areas where there's not enough dentists to be able to service the population. And the amount of dentists we're talking about is actually a very low bar. We're talking about like one dentist per 2,000 or so people. And yet there's still so many counties that don't even have that. All right, mental health care. One thing that we're really trying to focus on right now, especially in rural communities that have a disproportionately large loss of life to things such as suicide, really need mental and behavioral health resources. Many of the counties, and this is actually a map of the mental health professional shortage areas within North Dakota, have huge shortages in mental health care providers. So when we're thinking about this, it's really important to think about scope of practice. North Dakota doesn't allow psychologists to be able to start medication regimens. You have to go to a psychiatrist. But about half of those counties that are designated mental health care shortage areas have less than one psychiatrist per 15,000 individuals. And there's some of those counties that don't even have 15,000. They just don't have a provider at all. That's very few. But almost every one of these counties have at least one psychologist. So are there ways that we can think about North Dakota healthcare specifically and how we are able to get help to these rural communities faster? And that might be re-envisioning the role of counselors or psychologists or the people that they actually have access to. And that's a lot of what I work on, is I do research on these topics, but not only do I do research, when states have questions about, if we change this law, what would happen? I fly there and I talk to them about it. We discuss it, we figure out what's going to happen and how can we plan on healthcare being able to get better by finding rules that might have existed for 100 years or 50 years or 60 years in an entirely different situation. Now technology's changed. Now the ability to communicate has changed. Now the ability to be able to have a nurse practitioner service you, and if something's complicated, get a doctor on Zoom immediately to join in that conversation. That wasn't possible even 10 years ago, right? So now that a lot of this technology is changing, now that a lot of these needs are changing, how can we address these pieces? So let's talk about some of the room for growth within North Dakota specifically. So I'm gonna talk about some of the laws of what's happening here, because again, it's really important to know what's happening within your own community. All right, the first is sort of behavioral health. So there's some wins and some losses. A lot of states won't even let counselors diagnose patients. They're not allowed to say, like, you have depression or major depressive disorder, or you might have generalized anxiety, or you might have ADHD or anything else like that. This is one of the few states where your counselors or your psychologists are actually able to start diagnosing you, and they can start treatment through talk therapy. They cannot prescribe medications. So psychologists are unable to start this medication regimen. You do have to go see a psychiatrist, which the wait times in North Dakota are extremely long. It's 2 months or longer in almost every single county, except for nearby NDSU, because there's some psychiatrists that are employed by the school. Because of that sort of lag, it can take people months and months and months to be able to receive any sort of pharmaceutical needs, especially for chemical imbalances. But you can get diagnosed by a counselor or psychologist here. So that's one thing that we've seen in similar states might be useful in North Dakota going forward, is reimagining this role of the psychologist, and if they are able to start treatment, especially for rural communities. I don't know how many of y'all have grown up in farming towns like I did. How many of y'all know farmers? I'm assuming everybody in this room. Okay. It turns out that farmers, especially in Western and Midwestern states, have some of the highest rates of depression across any occupation. It is extremely lonely, it is extremely depressing, and it doesn't have the same community build that it had 30 or 40 years ago. So farmers, love my family, they're also stubborn. Getting them to the doctor once is hard. Try getting them to the doctor multiple times over 3 months. A lot of the time that's not going to happen. So being able to address these things early in the first or second visit to be able to get things moving is so crucial to being able to get people to have care. Because the more and more appointments that you want, especially in rural areas, especially in farming communities, the more interactions that you require, the more people are going to drop out of this. They're going to say, I'm not going through this, I am not spending this time on this, and I'm just going to live with what's going on, and that's detrimental to their well-being. Another thing that we can talk about is advanced practice registered nurses. So this is actually one of the ones where North Dakota moved first. North Dakota in 2011 was the one who allowed nurse practitioners to have full scope of practice. They were one of the first waves of states who allowed that. This ended up drastically changing the ability to be able to get health care and minute clinics and things like that into communities that did not have health care. It was revolutionary. This was also one of the first states that looked at, in 2019, expanding some of the rights of physician assistants and physicians to work together to figure out sort of like where the limits of their practice can be. Does the physician trust them to go off and be able to diagnose the patient, and then the treatment come from the physician later? This is also one of the few states that in their advanced practice registered nurse rules, they also included certified nurse midwives. So this is one of the states where certified nurse midwives also have full scope of practice. They have the ability, especially within counties that do not have a labor and delivery center, they do not have a hospital of labor and delivery services. Midwives can go there. They can have birthing clinics. They can have different sort of interactions with patients. This is really important because before that, what was happening is there was an extremely high rate of people showing up in labor in an emergency room having never seen any healthcare provider beforehand. You're going in blind at that point. You don't know what's happening. You don't know what the health is. You don't know what the history is. But when we started allowing certified nurse midwives within North Dakota to also be able to have some of these rights for the first time ever with different birthing centers growing up and different services being able to be provided in different places, people were getting checkups along the way. People were able to identify where there might have been issues with that pregnancy along the way. Maternal and infant health got better. There's been less maternal deaths during labor and delivery processes. There's been less infant deaths during labor and delivery processes. So North Dakota actually really moving quickly on that one. Congratulations. Another one, sort of the idea of physician assistants, where the physician and physician assistant relationship can be determined by those groups working together. This is one of the first states that allowed that. So you're really on the forefront here. There's still some places to grow though. For example, I talked to someone about this yesterday, but I don't remember who mentioned it. How many of you have gone to get your teeth cleaned, and then there's not only the person cleaning your teeth, but the dentist also tries to talk to you, and like your mouth's full of stuff, and they're talking to you, and there's two people in the room, and it's very frustrating, right? Yes, many of you. How many of you have left the dentist with a bill that was way higher than you expected? Some of you, yes. All right, so a lot of the reason for that is because there are limits to different types of dental therapy within the state. For example, dental hygienists, they can't treat your mouth alone. They have to have the supervision of a dentist. So it's not only that a dentist has to be in the building, the dentist has to be in the room. Some states have realized we have very few dentists, a lot of the dental hygienists, and technology has changed. We have the ability to 3D scan teeth and to be able to even have like the equipment choose what sort of pressures you need for each tooth in the cleaning process. These things have changed. So some states allow dental hygienists to do some of the cleanings and x-rays on their own so the dentist can focus on the more needed pieces, doing the root canals, doing the caps and the crowns that you might need by doing all these other pieces. North Dakota hasn't quite moved in that direction yet with dental hygienists, but hopefully they will soon. That's one thing that is also predicted to lower the cost of routine maintenance of dental needs within the state by about 30 to 40%, which is a lot, especially when you're talking about communities that, if you're going to the only dentist in town three counties over, it might be pretty expensive. This state also does not allow dental therapists. So you might have heard of dental hygienists, you might have heard of dentists, but since dental therapists aren't allowed in the state, you may not have heard of them before. They're sort of like a sub-dentist. They're the ones that they can do some very basic things that you need right now. They can do an extraction, they can do a temporary crown, and they can do a teeth cleaning. You'd be surprised, but those are some of the 3 most important things to do on a regular basis so that you don't have worse problems later. So you don't end up losing teeth, so you don't end up having to have full root canals. Those are one of the most important types of preventative dental health care that you can have, but it's not currently available in the state. Please talk to your legislators if you're interested in this. But you do allow, that's supposed to be teledentistry. Weirdly, this is one of the only states that does allow teledentistry. So if you are having a toothache, you can Zoom with a dentist to say, is this bad enough I should come in? That's kind of neat, especially if it might be a long drive time to a dentist. Optometrists are allowed to, in the state, remove foreign bodies. So if you come in and there's something stuck in your eye, they can help get it out of your eye, but that's about where things end. They're not doing laser eye surgery. They're not doing long-term glaucoma treatments. They're not doing anything else that in some other states they've now shifted to. And then finally, pharmacists. So within North Dakota, pharmacists have some of the strongest restrictions in any state. And this is actually extremely surprising because, again, there are thousands and thousands of pharmacists in North Dakota that are available in almost every single community, but there's not healthcare providers in every single community. So you need to think about routine care. So not only can they not independently prescribe, so saying like, hey, you ran out of your inhaler, let me get you another inhaler till you can get to the doctor, they cannot do that. You're going to the emergency room and spending $3,000. They also cannot prescribe anything related to like tobacco cessation or hormonal contraceptives or even COVID-19 vaccines. After the emergency laws at the federal level ended, they could no longer provide vaccines within the state, not only COVID, but I think almost any vaccine. So in many different states, if you don't have access of being able to go in for a tetanus shot because you're really far away from a healthcare provider, you're able to get that tetanus shot from your pharmacist. You cannot do that in North Dakota. So North Dakota has some real wins and it has some real losses. It has a lot of places where it's on the forefront of being one of the first movers towards addressing rural healthcare and getting providers into rural healthcare, especially when it comes to primary care, family care, gynecology, a bunch of other things related to how you are being able to survive on a daily basis and get the services you need. But there's also a lot that they lag behind in. A lot of this is related to things like behavioral health, routine care for things that might be manageable but you need medication for things related to like dentistry and optometry. There's still a lot of things to happen. Luckily, you have some pretty cool legislators in the state. And like I said, in my center, we don't advocate for any particular policy, but we do study these things. And if we have some really neat results, we show legislators like, hey, you're considering this bill, this good thing could happen, this bad thing could happen, here's the chances of them. If you wanted to engage further because you're just like, hey, this is something that like drives me crazy, you have the Challey Institute here, which I'm pretty sure would always love to have more hands on deck for looking at these types of things, especially within North Dakota itself and looking at access to rural healthcare here. Legislators in North Dakota are fine with me flying out and talking to them, but they don't trust me, right? They want people from their own community who have lived within this community, who understand the needs of this community. So if you ever want to get engaged further, a lot of it's just talking to your representatives, knowing who your representatives are, knowing if one of these bills come up saying like, hey, I think that that's pretty interesting. I hear that there's actually some results from this. This might be what happens if we were to, I don't know, allow dental therapists to do tooth extractions that keep you from having large infections where you might lose multiple parts of your jaw, right? So there's lots of ways that you can engage, and I would suggest if you're thinking about progress within the state and being able to make it so that people have access to not only healthcare providers, but allowing healthcare providers who want to provide services to do that without the barriers preventing them from giving services to their patients. This is one way that we can really start thinking about progress and flourishing, especially if in rural communities, it's really important. So with that, you had said 10 minutes left for questions. I stopped with exactly 10 seconds to go before 10 minutes. With that, my name is Alicia Plemmons. Feel free to email me if you have any more questions or you want to see any of the studies that I talked about today. I'm also available on Twitter. My center's available on Twitter. And with that, I will take questions if anybody has any. Yes?
What role does insurance play in restricting practice?
Okay, so what the question was what is the role of insurance in restricting these practices? A lot of the time, insurance will do whatever the rules for Medicare beneficiaries are. While they might change their reimbursement values slightly based upon RVUs, which is the rate of the different services being given credit, if the rules are that a practitioner can provide within that state, for the most part, insurance is going to say, okay, that's fine. We're going to go along with whatever the federal rules are here. So insurance doesn't have a huge role in it. They want more providers, and it's actually cheaper for them to reimburse some of these additional groups like dental hygienists or nurse practitioners.
That begs the question, does Medicare care?
Medicare does not care.
State runs on its reimbursement.
Yeah, so Medicare was actually one of the reasons why some of these expansions initially happened. There's currently some federal legislation going through right now. Like one of them, I think, is it's called the CARE Act, I think. It's one looking at being able to help nurse practitioners be able to get reimbursement in some states. So they were one of the first ones who said, we have an aging population. We are very quickly getting more providers, especially in underserved and rural area, or excuse me, more people within underserved and rural areas that we are having to reimburse for and find healthcare for. And we don't have enough providers to do it. So they were one of the first ones who started pushing for, well, what if we do allow additional forms of care? What if we start reimbursing for additional forms of care? The moment Medicare said we're going to start reimbursing for nurse practitioners, that's when a lot of states started saying, okay, well, we might recognize nurse practitioners as primary care providers now because we have the ability to reimburse them because many of our insurance companies are doing similar to what the Medicare beneficiary rates are. So yeah, it's neat. So insurance is actually sort of for this, Medicare is sort of for this. A lot of where the stop in the legislative process has been is from two different sources. One is unions. So a lot of the time unions don't necessarily want these policies because they don't want competition coming in that might affect the rates of pay that they're getting. They also sometimes do not want their practitioners leaving. So if you put additional barriers, practitioners may not leave as well. The other pushback has been from the American Medical Association most of the time. They have a Twitter campaign called Stop Scope Skill because, again, that's a question of compensation. So physicians may not make as much money if you have a lot of other options for people to be able to go to. They're very upset about this. One of the main things that they cite in their legislative testimony is that they're worried about quality and safety. And that's actually why many of us had started looking at quality and safety to begin with, because we said, okay, you said these laws cannot be changed because we're worried about quality and safety. Let's do hundreds of studies to figure it out. We're going to look at everything from foot debridements. That's where someone who may have been living with diabetes for a long period of time might have dead skin within their foot that do need to be removed. What happens in that case? This is actually one of the cool ones that actually happened a lot in North Dakota. What they found was once we gave nurse practitioners the right to be able to do things independently, not only were people able to get more foot debridements when they needed it, you weren't having amputations nearly as often in rural areas because they were getting that care faster. So things like that is just kind of interesting. I'm sorry, you've raised your hand like 3 times. What can I do for you?
Reimbursement, I mean, that's very important because primary care physicians are reimbursed at a very low rate.
Yeah.
Procedures. If you really want more primary care physicians who can see people with asthma and mental health disorder, you advocate for better reimbursement by CMS. Because insurance companies take their cue from Medicare and CMS.
So I think you're totally right on that. So for the people on Zoom, I'm just going to repeat a little bit of that, and it's the importance of reimbursement rates. Sometimes reimbursement rates are very, very low, especially for physicians because they are based upon what Medicare is and what their reimbursement rate schedule is. This reimbursement rate schedule is redefined every 10 years or so when they reevaluate the RVU system. So I'm going to give just also a little bit of context to that for why I think this is important. So this isn't something that my center particularly works on, but I think it's something really crucial to think about. So why do pharmacists in a lot of states where they do have the ability to provide vaccines or do very simple procedures, why don't they do it? Because in that state, they can't get reimbursed for it. Why are there a lot of nurse practitioners and physicians who don't actually provide mental health? Because there's some states without mental health parity laws where they're required to have reimbursement. So a lot of the key to even doing things, I think you're right, is starting with that reimbursement piece. If people got paid more for it, or they had the ability to be paid for it at all, you would have more providers offering those types of services. And that is above my pay grade to fix. I have no idea how to address that. But I think that that's a really important thing to remember, is that we can change scope of practice laws all we want, but if people can't get paid, people aren't going to do things. So that has to work hand in hand. Yes?
So on the issue of medications, I agree that people should get their medications as quickly as they need it, but every primary care physician, nurse, everybody I know who does primary care prescribes antidepressants, prescribe they diagnose, they prescribe. So why is the solution to expand the scope of practice for psychologists for medical training rather than to refer to primary care instead of secondary?
It could be both. And this is where there's been a lot of debate between the institutions for the American Psychiatrist Association and the American Medical Association, is where is that line for the ability to be able to prescribe? So primary care within this state does allow for the beginnings of treatment for psychiatric needs. But what they're supposed to do is within a year, at least refer them once to a psychiatrist. So that rule does exist within North Dakota. Now, is it actually done? Not often. And sometimes the referral is just telling someone that they should. There's a lot of limits there, but there are many places that don't necessarily have the same access to primary care. So if primary care stretched thin and psychiatrists are stretched thin, we're just thinking about one other avenue for it. Also not for addictive medications. A lot of the time when we're talking about psychologist expansions, they're not talking about like ADHD or something that might have habit forming needs, but things that are specifically for chemical imbalances that are diagnosable from the beginning. So things for like generalized anxiety or schizophrenia or other things that are, if they have a diagnosis for it, which that goes along with having over 3 long-term treatments by different groups. You've seen a psychiatrist at some point during that process, but allowing the psychologist for, if someone, for example, has been diagnosed with schizophrenia for a long time, went without their medication, wanted to get back on their medication, the psychologist being able to start that they go see instead of waiting 2 more months for a psychiatrist. So it depends. This is only allowing one more avenue. I'm not saying primary care is not the place for it. Like, go to primary care, go to somebody for help. But I want that somebody pool to be as big as possible if we can keep it safe, if we can give quality, and if we can keep lives alive. So I'm not saying there's anything wrong with referring to primary care. Refer to primary care, but maybe one more help could be helpful too. Yes?
So in addition to legislature and all of these licensed professionals, right? Is there any strategies we can take to increase the amount of licenses that are given to professionals, or to increase the supply of medical professionals?
Yes, great question. So for the people on Zoom, the question was, what can really be done to expand the number of licenses? Because that may be the solution. Okay, there's a couple different ways that different states have done this. So expanding the number of medical licenses, that's tough because the number of residencies is set by federal reimbursements. It's very difficult to have other types of residencies. So the number of new physicians each year is sort of capped, not a hard cap, but it is soft capped every year. So it's very difficult to give more medical licenses. Now, there are ways to be able to give more things like nursing licenses, and that's by changing the requirements for whatever the nursing license is within that state. That is also determined by the legislator working together with the professional associations. But you also don't want to go to no training whatsoever, right? No one should be doing surgery in the streets. Please don't get that from my presentation. But that could be something that they look at, what's the quality and safety of maybe allowing this one class instead of taking it beforehand, you take on the job training for it. What is the idea of including this in continuing education than something in the beginning? What is maybe the idea of stopping one barrier, being that some of the people coming into nursing are from low income communities and they may have this training, but paying $1,500 for a license in the state's very expensive. Maybe instead making that $200 or something that they can pay back after they start work. So there's different ways that they can work around it by thinking very, very clearly about what is the role of each of these things, doing different types of testing, and looking at what's happening within other states. One other thing that they can do is joining compacts. So some states like this, some states don't. North Dakota has joined some of the compacts for like nurse practitioners and things like that. And that's the ability for a out-of-state license to be recognized here. So that means the states have talked together. They have agreed, I like your training, you like my training. I'm going to let your nurses come in here. And instead of them having to wait 2 months to be able to get a license here, we're going to let them go immediately and start working. And we're going to take the background check from your state and things like that. So that's another way to be able to get providers sort of quicker that some states are interacting with right now. What has happened in that is that you do have more people moving, especially during emergency times. So we saw this a lot during the pandemic as places that were part of these different compacts were able to move travel nurses much, much faster, which was really important for some communities that were having large outbreaks but didn't have the support staff for large outbreaks. Yes?
This isn't a question about more of a comic stat. If you show maps, like show healthcare shortage areas, recruitment is really important in those areas in terms of getting professionals into programs. So if you look at like the University of North Dakota, there are only medical schools in the state. Priority, not the only consideration, but priority is to get the students who are from North Dakota, because those students are more likely to stay in North Dakota and serve the population that they grew up in versus somebody from Florida who would move to North Dakota. Very unlikely. If you grew up in Cavalier, probably more likely to come back and practice in North Dakota.
Oh, by far.
Similarly, there are reimbursement programs, especially in those healthcare shortage service areas, that offer like student loan repayment options. That's another great recruitment opportunity. What happens though is those students go for 3 or 5 years, they get their big chunk of loans paid off, and then they go.
So that's
but that's another maybe lever.
Yeah, so that's a really important one that I didn't talk about in this presentation because I'm mostly on scope, but we've done a lot with loan forgiveness programs too, and the ability to be able to get loan forgiveness programs. Like for example, one of the largest pushbacks for readjusting the primary care shortage area designation to include nurse practitioners is because then technically less counties would be considered, which means less counties would have the loan forgiveness programs. So they don't want to do that. So thinking about the role of those loan forgiveness programs is really important. One thing that we've seen in EMS and paramedics that we haven't necessarily seen for physicians enrolling in these programs or nurse practitioners enrolling in these programs is the working with the local government to say, yes, we will pay back some of your loans or we will provide you some housing, but you have to contractually be here for 8 years. And thinking about these long-term times after that repayment purpose of there's some services we're willing to do for you or some repayments that we're willing to do for you, but in exchange, we do need you to stay for this amount of time or you have to pay it back. That's one thing that we've seen been really successful for rural EMS services that I haven't necessarily seen in other healthcare pieces. So I'd love to see more on that, but I don't know, that's a huge policy piece. If any of y'all have suggestions, I'd love to hear them.
We're out of time now, so
Oh.
but you'll have time to ask questions probably in the audience. Let's get all of you.
Oh. Thank you for coming.